frequency ablation. We use a 17-gauge needle, which is inserted under ultrasound guidance into the intra-abdominal part of the fetus, close to the umbilical cord insertion, and a high energy alternating current is passed through the needles, which will lead to increase in the temperature and coagulation of the cord. So that is how we use that is a needle which is being introduced under ultrasound guidance. And then this is a small clip in which shows a reduction of a trap twin. So this is a normal twin, and then we have a trap twin. So under ultrasound guidance, we have introduced the RFA needle, and it is introduced into the intra-abdominal part of the trap twin close to the umbilical cord insertion, so that the umbilical cord is coagulated, and it's sort of leads to the demise of the twin we want to reduce, and the other twin is fine, and it avoids shunting of blood from the normal twin to the dying twin. So there are other techniques also. We can use other techniques to coagulate the cord, and RFA is it's less invasive, has good outcome. The other one is a bipolar cord coagulation, which would require introducing a bipolar forceps through a trocar into the amniotic sac of the twin we want to reduce. So this is basically more invasive because you may use up to 2.7 to 3 mm trocar through which the bipolar forceps is introduced. You have to catch hold of the cord of the twin you want to reduce, preferably close to the umbilical end of the cord, umbilical end of the cord of the fetus you want to reduce. So you're very sure that you reduce catching hold of the cord of the fetus you want to reduce and not reduce the normal fetus accidentally. And then current is passed to the bipolar forceps to coagulate the cord. And after the procedure, we would like to follow these patients, and we do a repeat ultrasound after 24 hours to check the heart of the remaining twin, and also to look at the middle cerebral artery flow to see if there has been any incidence of transfusion into the dying twin from the normal twin, which would be evident by increased MCPSV because of anemia in the surviving twin. And then we follow them after 2 weeks. We usually offer MRI after 28 weeks or 4 weeks after the procedure to the surviving twin to look for any evidence of cerebral injury. So is there any risk of neurology between 18 to 24 weeks? RFA would be less invasive than bipolar. Interstitial laser is also less invasive. We cannot use bipolar if there is oligohydramnios because you have to enter into the sac with the trocar cannula and then put the bipolar forceps through it. So short and thick cord RFA is better because bipolar may not be able to hold and occlude the cord. And the advantage of bipolar is simultaneously occluding both the umbilical artery and the vein. So the risk of transfusion from the normal towards the twin, which is dying, that is getting reduced, is less. So this is a recent systematic review which showed that RFA compared RFA to bipolar and found that the live birth rate is slightly less with RFA, but almost comparable. But bipolar was associated with a very high risk of preterm premature rupture of membranes. And the average gestational age at delivery was around 35 weeks. Fetuses are at a risk of preterm birth, PPROM. And also, co-twin death may occur in up to 15% after the procedure. This is another large studies in which they compared the bipolar cord coagulation, interstitial laser coagulation, and radiofrequency ablation. The survival rate was lowest with the interstitial laser, best with the bipolar, and then radiofrequency ablation also it was quite good. So in our initial experience, we also found that the overall live birth rate was lower with interstitial laser compared to RFA. So we use basically RFA for reduction in monochorionic twins. And in our experience, I have a survival rate for almost 77% live birth rate and 70% take-home baby rate. So maternal complications can also occur as either invasive procedures, NIPT and IPT also can be done after fetal reduction or selective termination. And there may be lab evidence of coagulopathy, but so these procedures are safe. So to conclude, pregnancy outcome in higher order pregnancy, that is 3 or more, can be optimized by multifetal pregnancy reduction. Reduction of twin to singleton is acceptable in selected cases. And of course, chorionicity is important to decide the technique, and also the outcome would also depend upon the monochorionicity, because higher pregnancy loss when you reduce monochorionic with multichorionic pregnancy. Thank you.
Thank you, Madam Matla, for clarifying, for clearly distinguishing the two between selective reduction and multi-fetal reduction, and the various methods available for both MCD and DCDA twins. Please, if we can hold on till we take questions at the end of the last lecture. Thank you once again. Rajat, would you want to add anything here?
No. It was a very good lecture, and we'll continue for the questions after. I know there will be several questions for this topic. We'll wait for the questions at the end of the session.
Okay. Rajita, can you introduce Dr. Pratima, please? Yeah.
Yes.
CV slide of Dr.
Slide.
Yeah.
I think as Dr. Sitaj told, all our speakers need no introduction. They're all great names in the field of fetal medicine. But to formally introduce her, she's Dr. Pratima Radhakrishnan. She's a FRCOG. She's Director, Bangalore Fetal Medicine Center and FGI Fetal Care Units. Director, FGI Research and Training Institute. Diploma in Fetal Medicine, FMA UK. She's the first Indian to obtain diploma in fetal medicine from FM Foundation, Fetal Medicine Foundation. She has diploma in advanced obstetric ultrasound BCOG UK. She is first to perform therapeutic fetoscopy laser in India. First to start on-site and online distance learning of blended process in fetal ultrasound, benefiting several doctors across the country. Special interest, her special in fetal diagnosis and therapy, early fetal screening and diagnosis. She is educational fellowships, online and on-site distance learning programs. She has flagship fetal ultrasound program and gynae ultrasound programs. With these few words, I invite Dr. Pratima to take on the stage and start sharing the screen.
And just I also noticed that you have won the DSV Mrs. Grand Medico Diva. So congratulations. Apart from her excellent being an excellent academician, we can see she also has excellent extracurricular awards as well. Thank you.
Thank you. Thank you so much, Sita. Thank you. Thank you, Dr. Rajat. And thanks, and wishing Bhaskar all the very best for the, for standing up for the FOGSI president. It's a lot of hard work, and I've heard so many good things about Bhaskar from my mother-in-law, because they work together for the RCOG, the All India RCOG meetings as well. So I bring blessings from her too, for Bhaskar. It's one of her favorites, honestly. Right. So with that, I will just move on to the discordant anomalies in twins. Now, to have a discordant anomaly in twin pregnancy is a big dilemma. And we are kind of stuck between deciding whether we should be managing this expectantly, or should we institute an in utero therapy if that's possible, or should just terminate the entire pregnancy, or maybe collect, importantly, the chorionicity. Now, the other thing important to think about is, when you have an anomalous twin, it is important to think how it is going to affect the normal twin, because that is also possible. Either it can cause a co-twin demise, it can lead to preterm delivery, and of course, causing neurological morbidity in the short and the long term as well. So you have got the whole picture in front of you, and you've got to think about not only just the anomalous baby, but how it's going to affect the normal twin also. And chorionicity has got a big role to play about how you're going to manage the pregnancy. So as like everything else, any twin pregnancy is not a twin pregnancy at all. Chorionicity must be defined, and you could have discordant, and of course that is detected in the first trimester with a very high accuracy. Now, looking at the discordant anomalies, looking at specific complications of monochorionicity, and of course single fetal demise, all these things are affected by the chorionicity. Now, let's look at dichorionic. I'm just going to take you through some case examples. This is megacystis in one baby, more than 15 millimeters, and of course the prognosis for that baby is guarded, we would discuss the possibility of aneuploidies, and options would be to do a double CVS, single CVS, and of course management is one of the four: expectant, selected, if there is an in utero therapy possible, or pregnancy termination. In this particular couple, they chose to do a double CVS because even though there was discordant phenotype, sometimes they can be sharing the same genotype even in dipole pregnancies. So once we do a double CVS and then the couple opted to go through a selective fetal feticide, and of course they delivered. The surviving baby went on to deliver at term, right? Now, before selective feticide, you can decide to do double CVS before or after, or you may decide not to do a CVS for that. Just reduce that one, but make sure that what is left behind is normalized. So you do have these options more for economical reasons than for actual clinical reasons. Okay. Now, sometimes it's not detected in the first trimester; it's late, and like the bilateral CTB. One twin, and of course the prognosis is good for that baby. There is the possibility of aneuploidies is rare. And how are we going to discuss the management? Of course, amniocentesis, preferably double amniocentesis, and go through an expectant management in this particular case, because obviously we know calopecia is something that one can live with. It can be treated very well, so the couple would choose an expectant management. Now, I know Vatsala did go through this about the multifetal pregnancy reduction versus expectant management, and what fetal reduction, even in dichorionic twin pregnancies, has shown that it significantly reduces the risk of preterm delivery with a higher birth weight, and no difference in the risk of miscarriage, or hardly any difference in miscarriage. So we know that reducing dichorionic twins does have a good perinatal outcome as compared to expectant management. Now, timing would depend upon when you would detect obviously the earlier the better, because the risk of miscarriage is proportional to the risk of having to later stages, right? And of course, need to make sure that post procedure also you have a follow-up plan when you do fetal reductions. Now, these are called selective fetal reduction because you're selecting the fetus which is anomalous to reduce. Now, we looked into our own data to see whether there was a difference in risk of miscarriage in discordant twins as compared to reducing concordant twins. So we compared 64 discordant twins to 65 concordant spontaneously reduced twins, out of which about 50 of the discordant twins had a selective fetal reduction before 16 weeks, that is the reduced group, and 14 were managed expectantly, the non-reduced group. So we compared that. So we looked at the double fetal loss, and double fetal loss was higher in the non-reduced group and before 20 weeks. The single fetal demise, of course, would be possible only in the non-reduced group, and half of them had a single fetal demise. And the concurrently spontaneous, the single fetal demise was at only about 10%. We had compared to single life, there is some disturbance.
Shama, please mute yourself. Shama. Admin, can you mute?
Okay, so single live birth, and in fact, single live birth preterm was about 15% in the reduced discordant reduced group, as compared to nearly 50% in the non-reduced group and 30% in the spontaneously reduced. This definitely made a difference in preterm delivery. And of course, the majority of them, more than 80%, 85% of them delivered at term. So all these things show that when there is discordant anomalies, probably the reduction is a better way to improve the outcome for the singleton fetus. Now, late selective fetal reduction again could be between 16 to 32 weeks, or it could be beyond 32 weeks. And there is a slightly higher rate of pregnancy loss. There is a risk of severe preterm delivery in this group and consequences, of course, of the severe preterm delivery. Whereas beyond 32 weeks, there is increased risk of preterm delivery, but the kids because of but the surviving twin is likely to do better and the major disability is less likely. But there is a danger of terminating the wrong fetus, particularly if there are discordant markers and then you have proven discordant anomalies, proven discordant aneuploidies, but the marker can disappear. So occasionally we may need to even do speed amniocentesis, actually normal but discordant chromosomal or genetic abnormality. So one must not hesitate to do this if you're not sure about which twin you are going to reduce, right? So with that, I would move to monochorionic twins. Now let's look at another example. There's acrania in one fetus. The prognosis is very bad. Again, the management options remain pretty much the same. In this particular case, they opted for selective fetal reduction, and of course, the other fetus went on till term. When we have multiple anomalies in one twin, of course, even in monochorionic pregnancies, you can have discordant anomalies and structural anomalies, and occasionally discordant aneuploidies as well. Okay, so let's not presume that all monochorionics will have. It could have different phenotype, and sometimes they can differ in genotype also, right? So in this case, we did double amniocentesis, and the couple opted to do a selective fetal reduction of the abnormal twin. And of course, Vatsala has already mentioned this. I'm not going to go through this, but there are, in selective termination, monochorionic must be vaso-occlusive techniques, and these are done under local frequency sedation. There is bipolar cord. Look out
Recording
for
in
preterm
progress.
membrane separation and preterm delivery, right? So selective termination must be after 18 weeks. Okay. Timing, is best performed after 18 weeks, and one could choose from whatever what one can choose from the method of termination that one is comfortable. I personally go for interstitial laser because I'm just much more comfortable as compared to RFA and PCC, of course. And of course, you have to have a pathway for post-procedure follow-up as well. And much thinner instruments are available, and it minimizes the operating time. And that's why I prefer the fetoscopic laser as well, because I just use an 18-gauge CVS needle for that. So to summarize, when we have discordant anomaly in twins, the first and foremost thing is to check the chorionicity, to assess the lethality of the anomaly. Is this baby going to die in utero, or do we have time for this? So in case of dichorionic and monochorionic, so I'm going to cover these two things separately. If it is dichorionic and if it's a lethal anomaly, the baby is going to die anyway. So you may choose to go conservative, okay, and allow the death of the anomalous twin to happen naturally. If it is non-lethal, also you can go conservative, depending upon, of course, what anomaly it is. Like there could be a non-lethal anomaly, but with a high morbidity. For example, there is a severe brain abnormality. It does not have a high mortality, but it has got a very high morbidity. And in these cases, you may have to choose to go with selective termination. On the other hand, for monochorionic, if it's a monochorionic lethal anomaly, so certainly selective termination as soon as possible. If it's non-lethal, again, depending upon what the parents' wishes are, you may go conservative. But if it's causing high morbidity, then again, you need to do a selective termination. What is extremely important is when we are considering continuation of pregnancy or selective termination, we need to assess the risk of premature delivery, because this is one of the biggest challenges with and without doing selective reduction. Without doing selective reduction, if it's continuing as twins, we know that there is a high risk of premature delivery. And is that risk for premature delivery worth taking with one baby being abnormal and one baby being normal? So we need to look at the past history of preterm delivery. We need to look at if the fetal anomaly is likely to cause polyhydramnios, and very, very importantly, selective cervical surveillance, cervical length. And in these cases, if there is anything significant there, then you may have to do selective termination at times where, at unusual times as well, maybe even at 20 weeks or at 24 weeks, and take that additional risk of miscarriage, because what you don't want is the woman to go through a preterm delivery either, or at 28, 26 weeks. So again, it really differs from case to case as to what is the progression, how the pregnancy is progressing and what's happening to the cervical length. If there is a progressive shortening of the cervical length, then I would choose to do a selective termination as opposed to having a good stable cervical length. Okay. So in short, discordant anomaly and selective termination certainly avoids the live birth and long-term survival of a severely impaired child or a child with lethal abnormalities, and that's obviously the aim of the pregnancy, aim of the selective termination. It optimizes the outcome for the normal fetus. But remember that if there is a twin pregnancy for the parents, if there is one normal and one abnormal, even postnatally, all the attention goes on the abnormal child, and there is a lot of attention given to the abnormal child. And in that process, the normal child goes through attention deficit problems as well, and a lot of psychological problems in the long term. So this also issue needs to be addressed. As much as people want to have kids, I think when it comes to twins, we need to think about, need to think more for the normal fetus primarily. So loss rates after selective termination, it's important to give them the appropriate figures of what is your specific loss rate and counsel the couple well. In monochorionics, of course, we need to use vaso-occlusive methods. And as far as the technique is concerned, in monochorionics, I would say whatever one is comfortable with, that's what they should be used. So with that, I will conclude my talk. Thank you very much.
Thank you, Dr. Pratima. As you rightly told, it differs from case to case. We have to be selective in every case, taking into account what is the lethal possibility, lethal abnormality, and high risk of morbidity. Thank you.
Thank you, Pratima, for that brilliant talk as always, and clearly depicting that we need to individualize each case, and please, it's not the end of the world, so please do not terminate the entire pregnancy. There are options of, even if it's monochorionic or dichorionic, there are options. So there's one question for Vivek which he has answered, but for the benefit of delegates, I'll read it out. So somebody has asked that, can we correlate the findings that we saw on postnatal dye injection studies with the outcomes? Can we do it antenatally? So Vivek, we want to answer it. Is he here? Or I'll read out his answer. He's explicitly answered it, but yeah.
Yeah. So as I said, the two concerns that we have with placenta, monochorionic placenta, is unequal sharing and teratotal discordance. Now, teratotal discordance, to a fair extent, you can predict by looking at the cord insertion sites by around, let's say, 12 weeks or 16 weeks of gestation. But as I said, teratotal discordance, the weight discordance that you would expect in these twins need not always faithfully follow the teratotal discordance because of the balancing role played by the anastomosis. That's why the natural history of SFGR is difficult to predict, because just by looking at the cord insertions, you cannot say that this is going to be the outcomes, which is the basis of the Grata-Costas classification, where the classification is based on clinical behavior rather than the placental cord insertion. Now, what you cannot see by ultrasound are the anastomosis. Then as long as you cannot see the anastomosis on the ultrasound, you can only speculate in retrospect and say, okay, this is probably what is happening in this particular case. The final answer can only come from postnatal dye injection studies.
As of now, we only have what we have with us, nothing more than that, yeah? In terms of weight discordance and insertions of the cord. There is a comment for Dr. Vatsala. I have a question. Do you have any experience of monochorionic pair being reduced and they don't turn up. You reduce one of the pairs and the pregnancy continues early in gestation, and they continue to term you got my question? I don't know if you want.
You're reducing one of the monochorionic and it doesn't reduced.
So the one has reduced and the other continues with the other pair there, but it actually there is no effect of the reduction on the other monochorionic pair. Have you experienced that? Like we try to reduce one of the monochorionic pairs and expect that the other pair will get reduced or call them for follow-up, but they don't turn up.
At the time it doesn't happen. You have to reduce them separately. If you're reducing a pair, you have to do it. It's not that you put, like if you want to reduce a monochorionic pair, you put casein in one, the other gets reduced. More like, I don't think it's happened. Like I have had to reduce the other one. So.
Right. Yeah, Aparna, want to say something?
So the anastomoses are not so well developed when you're doing it in the early pregnancy, perhaps.
Yeah, I think what ma'am is saying is that, like, I agree. And, I have had cases where, around 3 to 4 patients where I reduced one and called them the next week and the other one spontaneously reduced. So that happens a lot of times. And in fact, there is actually a lot of people who believe that very early on in pregnancy in a monochorionic twin, the anastomosis is not like, so much that it's going to affect. So if that pregnancy continues, let it continue. So
Absolutely.
in fact, the Gratacols team actually, what they do is they say that, okay, even if you reduce one, I mean, that's something, but I would not say that in like, so what is in very early on in pregnancy, we believe in reducing both. That is for the public platform. Let us keep at that. What you're saying is currently experimental and let just be at that. Okay. But we have had patients that you reduce one, but after 1 week, the patient comes back and the other one gets reduced by itself. That is more commonly seen.
Because even like first trimester, if there is like demise of one of the monochorionic twins, the risk of neurological damage is
still there.
Not much actually. I don't know, it's not really much reported, but it may not be as high as when it gets there's a demise later in pregnancy, in the second trimester.
There's another question for Vivek saying that which dye do you use, if I'm seeing the right one? And how quickly after delivery can we do these dye injection studies?
Which dye? Okay. So we have tried all sorts of permutations and combinations, but what works best is diluted poster colors. You get either fabric paints or poster colors. Add some water to dilute it so that it's thin enough to push it through, and then you get very vivid colors on the placental surface. What you have to do basically is to wash the placenta completely as soon as possible after delivery. The more you wait, the lesser your chances of complete dye injection. If you have to wait, make sure that you don't put it in formalin. Rather, you put it in saline or keep it off in the fridge and then try and inject the next day or day after. The latest we have injected is probably second day or third day after delivery, but in a well-preserved placenta in the refrigerator, not in the freezer compartment, in the regular compartment. You milk out all the blood clots, and as you inject, you keep pushing out. You keep milking the vessels on the surface, and then it beautifully flows. Even if there are clots inside, just gets dislodged. So poster colors, diluted poster colors or fabric paints is what we've seen works best. Some people use milk, which gives you a very clear white appearance to the vessels. You can use white poster colors as well, whichever color combination you want. But I think I would suggest that you stick to one standard set of colors for one set of twins. For example, if it's twin A, always use blue and red. For twin B, always use yellow and green. So that when you're collecting cases, it becomes a lot easier to retrospectively look at data rather than experimenting with Portugal and Argentina each time. It's good to stick to one set of colors.
Thank you. And just to comment for Pratima's talk, I think it's important also that the person who's doing the invasive also does the termination as well, so that we know there's no discrepancy there. Do you agree to that, Pratima? Your comments on that?
Absolutely. I would ask them first, where are you going to go for the reduction if it turns out to be abnormal? Only if they agree to do the reduction with us, I would do the CVS. Because I think, and even in our unit, because we have few fetal medicine consultants now, whoever does the CVS or the invasive, diagnostic invasive will do the reductions as a protocol.
So, ma'am, can I just add to the early MCDA reduction? So this is my thesis when I was doing my fellowship in Mediscan. So what we did was for around 190 odd cases, inject one of the monochorionic pair today, call them back after 24 hours. And 97% the other twin was taken out. So that's a very high percentage of co-twin reduction in monochorionic twins early in pregnancy when you inject just one. I don't know if that's the same experience with the others, but this was part of my thesis when I did my fellowship.
Well, when you say early reduction, how early is early? Really?
Between 12 to 14 weeks.
12 to 14 weeks, yeah, because
Yeah.
I'm paranoid. I reduce weeks.
Reduce both. Yeah.
Yeah, I reduce always. I mean, it's not a big deal. I mean, your needle is in any way, and you just go a little bit further, and it just takes literally less than a minute longer.
So would you go transamniotic as well?
Yeah, transamniotic, transplacental, whatever. I just go and just reduce them.
No, through the intertwin
I
membrane.
only avoid the survivor's sac and placenta.
Okay.
The one which you're going to reduce, it doesn't matter if you go through the placenta or through the sac, you know.
Yeah.
Yeah. So, and interestingly, you say 97% is very high, actually, co-twin.
Yeah.
Because what Kypros' paper describes as 50% in monochorionic. Because they did that in dichorionic triamniotic twins, where they tried to reduce one and allow it to continue as a dichorionic twin. But in half of the times, they lost the other one as well. So
in our series of 190, I think there were just 6 or 7 cases that needed a second injection the next day. I don't know if it was selection bias, but this was prospective study. It was not retrospective data. It was prospective study in I think close to a year was the study period.
Yeah, but then also for them to come back again.
Yeah.
You have to be absolutely sure that they come back.
Which is why I was saying, like, a lot of these people come from remote areas where they've had IVF, and then they don't tend to follow up, after a week.
I would feel much more confident when they go that both of them are reduced. Rather than just.
Dr. Meenu has something to add. Yes, Meenu. Thank you for joining. We can't hear you, Meenu?
Am I audible?
Yeah, you are now. Yeah.
I think I just wanted to say the same thing that Pratima ma'am already said. I mean, even in our institute as a protocol, when we have to reduce a monochorionic pair, we make sure that we inject KCL in both the fetuses at the same time due to various reasons. I feel one, as ma'am said, is compliance. Second, in a few number of cases where you would see that the cardiac activity is still there, I think it's very emotionally or mentally traumatic for the patient to, undergo the same procedure again, or to leave her saying that, there is a probability that nothing would happen to that fetus. So if the patient has agreed to continue as a singleton pregnancy, we do not take the chance of not putting KCL in the other fetus. We inject KCL into both and do a repeat scan after 24 hours the next day. And if the other baby is fine, she's left for follow-up.
No, we do the same as well. I was just saying about the thesis that I did, because that there's quite a possibility that there is more than a 90% chance that the other one could be taken off.
Once to that question of compliance, the biggest issue
biggest issue is compliance in India. Biggest issue is compliance.
That uncertainty
may not come back.
Done back or not in our scenarios is really huge. You cannot take that risk and leave the patient like that. That was
true.
Yeah, I think thank you so much for that, and we'll end this session. And thank you once again to all our excellent speakers, Dr. Vivek Vatsala and Dr. Pratima. Thank you so much. And over to you, Prasanna. We're waiting for.
Thank you so much. Thank you all the speakers. Thank you so much.
Thank you, Rajat.
Thanks to respected chairpersons and all our respected speakers for those brilliant deliberations and interactive discussion. I request Himanshu to play the industry video before we start with the panel.
From the sandy shores, where a couple stands hand in hand, witnessing the birth of a new day, to the boat sailing towards the horizon, seeking its abundant catch, the rising sun signifies a fresh start, a beacon of light guiding us towards a healthier future. A mesmerizing sunrise, symbolizing hope, transformation, and possibilities heralding a new beginning. Just as the sun's rays fill the sky, illuminating the world around us, we at M-Fine Diagnostics are here to illuminate the path to a healthier tomorrow with the promise of transformation. In this symbolic moment, we invite you as M-Fine Diagnostics, formerly known as LifeCell Diagnostics, embarking on a journey to revolutionize India's healthcare system. With the recent acquisition by LifeCell Diagnostics, M-Fine Diagnostics combines the strengths of two leaders, forging a path towards a healthier India. Our commitment to excellence, nurtured by years of experience, will redefine the way healthcare is delivered.
At NRL, we cater to a test menu of 3,000 plus tests. These are all specialized tests, and they cover various high-end specialist tests like genomics, karyotyping, FASH, newborn screening, prenatal screening, immunohistochemistry, allergy, and flow cytometry.
Come, let's explore a realm of innovation and compassion. Here, the convergence of science and care sets the stage for a new era in healthcare. Inside our state-of-the-art facilities, skilled medical professionals work tirelessly, employing the latest advancements and breakthroughs. We believe in leaving no stone unturned in our pursuit of accurate diagnostics and comprehensive care. With M-Fine Diagnostics, you can trust that your and your patient's well-being is in the hands of dedicated professionals, guided by a shared vision of transforming lives. At M-Fine Diagnostics Lab, we combine expertise, advanced techniques, and timely reporting to provide you with the most reliable histopathology services. Trust us for accurate diagnoses and comprehensive solutions. Our integrated departments and highly trained professionals equipped with advanced technology deliver high-tech tests with speed and accuracy. Automated sample management guarantees faster results, while our focus on quality is unwavering. At M-Fine Diagnostics, we prioritize seamless experiences for patients and doctors. Our dedicated customer care ensures hassle-free services, patient convenience is key, and we offer real-time logistic tracking, allowing patients to stay informed about their specimens. With strong logistics support and real-time sample tracking, we ensure smooth operations. Our mobile application provides a flawless user experience, enabling easy test searches, bookings, and result downloads. Our enhanced customer experience includes auto-routing bookings to the nearest available phlebotomist and a user-friendly portal/mobile app. Our skilled phlebotomists collect samples efficiently, maintaining specimen integrity during transport to the lab. Adhering to NABL and CAP guidelines, we uphold the highest quality standards in the industry.
Together, we can set new benchmarks of performance and excellence across the country. We are excited to collaborate with you in catalyzing game-changing diagnostic innovation for those who need it most. Thank you for your support.
We again thank LifeCell M-Fine for being the trade partners for Vision webinars. Now we start with the panel. I request Himanshu to share the CV slide of Dr. Aparna Sharma. Ma'am will be the moderator for today's evening panel. Dr. Aparna Sharma, she is a professor in Obs-Gynae at AIIMS, New Delhi, and she was the past secretary of the Society of Fetal Medicine, a receiver of various awards. We welcome you, ma'am, on Fetal Vision webinars.
Thank you, Dr. Prasanna.
Can I request you, ma'am, to invite all the panelists?
Right. So, very good
Can
evening
we
to
have
all.
the CV? Yeah.
A very good evening to all of you, and I would like to thank Dr. Bhaskar Pal and Dr. Sita for having me here today. And after the 3 brilliant lectures today, we have the panel. And for that, we have our esteemed panelist, Dr. Akhila, who is the professor and unit chief in the Department of OBGYN at Kasturba Medical College, Manipal. Welcome, Dr. Akhila. Next, please. Dr. Asit, who's the assistant professor at Department of OBGYN at IMS Hospital at Bhubaneswar. He's a fetal medicine specialist from Bhubaneswar. Welcome, Dr. Asit. Next, please. We also have with us today Dr. Kirti Sharma, who is the founder director of the Kalavati Fetal Medicine Center, and she's also a fetal medicine specialist. Welcome, Dr. Kirti. We have is from Hisar, and she is a fetal medicine specialist from Hisar. Welcome, Dr. Kritika. And we have with us Dr. Meenu Batra, who is from his faculty and fetal medicine consultant and specialist from CIMAR. Dr. Meenu is also the Joint Secretary of Society of Fetal Medicine. Welcome, Dr. Meenu. We have with us Dr. Soumya Srivastava, who's a consultant fetal medicine from Santa Vita Hospital from Jharkhand and a member of the Society of Fetal Medicine. Welcome, Dr. Soumya. Very warm welcome to all our panelists here. So after the 3 lectures, so initially to make this case-based panel on multiple pregnancy, I was trying to walk the tightrope because I had to avoid all the topics which have already been covered by our brilliant speakers. So I think you can understand that it is a difficult job. So I decided to go and, do the basics. So what we're going to do today is cover some of the challenges that we face when we manage multiple pregnancies. We will be dealing with the basics, but the difficult situations in the multiple pregnancy. So to help with that, we have very experienced panelists with us. We do understand that when we deal with twin pregnancies, we have the 6-step approach to twin pregnancies, in which we have the gestational age assessment, assessment of chorionicity, screening for aneuploidies, the complications of twin, monitoring twin, management of complications, and timing of labor and delivery. So we will be touching upon all of these in some measure. We'll try to make this simple. And as we go on, it will be a case-based discussion. So the premise is that the answers are out there. We just need to ask the right questions. So we will begin by the questions from scenario 1. And I'll request Dr. Akhila to take this scenario. So essentially, whoever wants to, really add a point or has a viewpoint is most welcome to, butt in and tell us more about the situation if they feel so. So we start with the first scenario, in which we have a primi gravida. She's a dichorionic twin pregnancy. Like we said, there is no twin without the chorionicity. So we talk about the gestational age. She's 12 weeks and 6 days and a dichorionic twin pregnancy. Dr. Akhila, and when she presented to us, she presented with an absent nasal bone in the first trimester in one of the twins. So Dr. Akhila, how would you, I think this is a very common situation that we come across. So what do you want to know more, and how would you go about this?
Thank you very much, Aparna. So we have a dichorionic twin here, and we all know that 10 to 20% of dichorionic twins can be dizygotic. So when one has absent nasal bone, we may be dealing with a situation where we are dealing with 2 different karyotypes. So since I think your next question will be NIPT versus invasives, if I assume so.
Yes. So would you like to do something else? So basically, in this particular situation, I'll just give you that, she came with this report of the first trimester screening, which she also had done at the time of presentation, that she presented that her nasal bone was absent. However, her first trimester screening biochemistry, which she did, was low risk. I mean, it was borderline for the twin 1 and twin 2. Right. So the first trimester screening, because she has done and she has an absent nasal bone, so it was calculated for fetus 1 and fetus 2. So it was more than typically the cutoff of 150. So how does this help you, and what would you want to do next?
So if the absent nasal bone is already incorporated into this and the risk is given as 1 to 87, is that right?
Yes. So absent nasal bone is incorporated. And with this, yes. And with this, the risk comes out to be 1 in 287.
So see, if it is a singleton pregnancy, we know that it comes under this intermediate risk, and NIPT would have been a good option. All of you know that. And we also know that when twins are looking the same in the ultrasound, when there is no abnormality in the ultrasound, NIPT still remains a very good screening option for twins. So that also we know. But now that we are dealing with 2 twins with 1 absent nasal bone and 1 not showing any marker of aneuploidy, we have in the back of mind that we may be dealing with 2 different karyotypes. Then NIPT, I think, loses its role. And then we have to think of invasive testing here. So that is what the literature also says, Aparna.
Right. So Akhila says that, okay, of course, we have the option of doing NIPT versus invasive testing. So what you're saying is absolutely correct. So we have the option of doing NIPT versus invasive testing. So FTS in twins. So just to give a background, FTS as a primary screening method is quite good when you compare it to singleton. It has the same detection rate as compared to the singleton pregnancy. So as a primary screening method, we do offer FTS, which was done in this particular case. NIPT in twins, if we talk about it, is currently the most accurate method for screening for trisomy 21. So if a patient asks us, we can say that yes, NIPT is a good option. But as Akhila is saying, that because we are suspecting that there could be, there could be a background risk, that there might be some additional problem, do we consider invasive testing? So yes, it is, we offer this to the patient. It is up to the patient to decide, because we tell the patient that the detection rate for NIPT for 21 remains 99, 18 remains 93, and the latest data shows that it is 99, 93, and 95. So it is a reasonably good method to detect these three aneuploidies which are associated with absent nasal bone, and offer these numbers to them. And then, of course, let them decide. But Akhila, I just want to know, you are offering the invasive testing, right? So the patient is very worried and says, oh my God, is it going to increase my risk of abortion, right? Of course, you're going to put in 2 needles, right? So you're going to say, I am going to do 2 needles. Will it not increase my risk of abortion? So that would be my next question. NIPT versus CVS, does it increase my risk of abortion? And the next question would be, oh my God, CVS in the first trimester, is it not a more difficult procedure versus waiting, getting a second trimester scan done and go for amniocentesis? So what would you do about it? What is your opinion on it?
So if you compare invasive testing in singleton versus twins, definitely there is a small increase in the risk of miscarriage, that is procedure-related miscarriage. But there is hardly much difference between CVS versus amnio. So it all depends on how well experienced is the operator while doing a double CVS, and how well you can get the trophoblast without getting contaminated from the other placental trophoblast. So there's not much difference between CVS and amnio if you know how to do it well. But if you compare it to singleton, there is a small increase in the risk of miscarriage. Yes.
So thank you for a very clear message. I think the crux is that the twin procedures should be done by experienced people who do fetal medicine procedures very, very routinely. And there is a very interesting meta-analysis which in 2020 in a recent data which says that if you actually do a procedure, it should be done by experienced people, but the background rate of doing a procedure is not actually different from the background loss rate of a twin pregnancy, because the twin pregnancy itself has some of the loss rates. So essentially, if you're doing the procedure well, whether it is CVS, whether it is amnio, the procedural loss rate is not more than what the background loss rate is. So we can, of course, reassure the patient that, okay, by doing a procedure, we are not increasing your loss rate, but of course, it should be done by an expert who's sure that they are sampling 2 sacs, they're sure that they're sampling 2 placentas. So be rest assured. Of course, there could be people who don't want any needle to be inserted. Then they have the option of doing NIPT. So all of them should be, all you put all of that on the table and tell that NIPT is accurate and safe, and it may be offered earlier, and invasive testing presently does not show an increased risk. And hence the ultimate choice rests with the patient. Interestingly, this patient underwent an NIPT and the NIPT came out to be low risk. And she also underwent an amniocentesis. The report is still awaited. So you know how the patients are, that they were still not happy. She was a primea gravida. She wanted 100% surety, and we are still waiting. I think the report is going to come tomorrow. So this was a video of amniocentesis, but I don't think I'm going to share it right now. So for the sake of time, but yes. So like we said, we can conclude that if the patient doesn't want to undergo a procedure, NIPT does offer a very good method for 21, 18, and 13. And in hands of experts, the procedural risk is not very high. So I think that is what I would like to conclude from this particular case. So Dr. Asit, quickly, can you tell us in a few words about how do you approach screening and what is your routine practice for screening in twins? Any twins which is coming to you, what do you offer as first line method?
Yes, ma'am. Good evening, everyone. Thank you, ma'am. Yes, as we know, screening in twins is of paramount importance, and all guidelines they suggest that we screen for aneuploidies in twins. As we know, monozygotic twins they share the same genetic information, so the risk calculated is pregnancy specific. Whereas in dichorionic twins, each fetus has its own aneuploidy risk, so the risk calculated is fetus specific. So in the first trimester, guidelines suggest that we go for a combined screening which includes maternal age, nuchal translucency, and serum biochemistry. And the risk is calculated either pregnancy or fetus specific. If the patient presents to us in the second trimester, we go for a quadruple test. And as we discussed, NIPT is a very good option if available. It is like as good as in twins in singletons, and obviously it's in better in monochorionic than dichorionic. So it can also be used as a first line or second line wherever applicable. And I may also add, in case of vanishing twin, if the fetal pool is still measurable, we would avoid doing biochemical screening and NIPT.
Right, right. I think this is very nicely summarized, Dr. Asit. You have just put in all the points together, and we can conclude that case scenario from there. So I would go to the next case scenario. This lady is a 28-year-old, primi gravida, 12 weeks, a DADC twin again. Now, the 12-week scan, it showed a discordance, right? It started with a discordance of 12.9% at a 12-week scan. CRL discordance was 12.9%. So, Dr. Meenu, I would request you to talk about how do we define discordance in the first trimester and the later trimesters, because this is an important parameter on how these babies are growing and how they're going to do later. So how do you go about it, and why are they so important?
Yeah, so when it comes about discordancy, first thing that we have to understand, discordancy, some amount of it is a norm in twins. You will never have two twins having the same CRL or having the same BPD, HC, AC, and FL. But the concern arises, how much is normal? So when you talk about calculating discordancy, in the first trimester, we basically look at the CRL discordance, where you're looking at the difference between the CRL of the larger and the smaller baby, and you divide it with the larger CRL, and then you look at the percentage discordance. Now, the same formula you would apply in the second trimester, where the CRL will get replaced by the estimated fetal weight, as you have shown in your presentation here. So when it comes to discordance, we always look at the discordance taking the largest CRL or the largest growth as the standard, because we do not want to assume that the larger one is growing larger and miss on the growth restriction in the smaller fetus. And therefore, if you, in the first trimester, if you have a CRL discordance of say 10%, that is what would be significant, even though it is not a very, I would say, a very good predictor of poor perinatal outcome. So roughly in dichorionics, it is around 15%. And in monochorionics, if a discordance is there of around more than 10%, you are worried not only about growth related in monochorionic, you're also worried about the vascular complications such as TTTS and so on. Now, coming to the second trimester, when you're talking about the estimated fetal weight discordance, if you find that the estimated fetal weight discordance is more than the 25%, then you are worried about complications, especially in monochorionics. You are worried about complications such as selective fetal growth restriction.
Right. So like you said, that you cannot have babies who are very similar. No siblings are actually very similar. So this particular study said that yes, up to 25% could be similar. In DC twins, up to 20%, up to this much of discordance is actually acceptable at 20 weeks and 30 weeks. And this is exactly what this study also says. And once you cross that limit, there is increased risk of stillbirth and neonatal death, which has been, documented in these studies. And hence, this is the ISWOG guidelines, which says a CRL discordance of 10%, like you said, and an intertwin discordance of more than 25%. So what happened to this baby? So it started with a CRL discordance at 12 weeks, but by 18 weeks, the discordance increased to 32%. Now, once the discordance is at 32%, so we know that, yes, this is a significant discordance. But before we go on further on the aspect of discordance, I want to touch upon something else, which is also extremely important. And Dr. Kirti, which charts do you use for twins? Have we shifted to twin-specific charts, or we are still continuing on singleton charts? or should we shift? I'm not sure that all of us are using twin specific chart, but I think it's time that we talk about it. So what is your view on it, and why are they important?
So what happens when we compare growth between a singleton pregnancy and a twin gestation? In a twin gestation, whether a dichorionic or a monochorionic, we see that growth lags up to 16 to 20 weeks, then catches up between 20 to 24. But after 24 weeks, you have a subsequent lag in growth which continues up to term. Now, knowing that, what happens if you use singleton graphs to plot twin gestation? If you use singleton graphs, you are after 24 weeks going to overestimate your cases of SGA, if not wrongly label them as FGR as well. So given until now there was a paucity of data because most studies were observational, but now we have enough evidence where we have formulated twin charts. And so ideally it is now recommended that we use twin specific charts. In fact, 2024, I think FMF group under Professor Nicolets has also come up with a twin specific chart as lately as this year, where they've also specified the centiles. So even if we don't move to the charts, we can use those centiles at least to start off with. And so we definitely twin specific leads to less dense surveillance and more better selection of patients who need surveillance.
Right. Thank you. I think this is time that we start talking about it. And in my practice, definitely, I have not yet shifted, honestly. But yes, I mean, we have to start thinking about it because I was just going through my data of last 6 months. And all of our twins are like, being as like, stage 1 FGR, stage 1 FGR. And, that thought, that got me thinking that, yes, maybe going forward, we will start putting them on centiles and see that probably our FGRs are going to be less. And that is what, these validation study told us, that there is reduced number of twins which are diagnosed as FGR. And if we actually use that, the use of singleton charts reduce the number of twins who are misqualified and could reduce the unnecessary interventions. So I think we can all talk about it. And based on the available evidence, this was FIGO 2021, that it should be considered that it seems reasonable to use twin-specific charts to avoid potential overdiagnosis. However, as recent as February 2023, this was a letter to the editor in AJOG, which actually said that let's not jump too soon. We need more validation. We have to have more research efforts. So I think this is something which is ongoing. We cannot say that, okay, jump onto the bandwagon and start doing this. This is currently under research. And at fetal medicine centers, we should definitely do a comparison and see what is happening and if we are going to, get more data out of it. So I think that is where it is. So Dr. Soumya, how would you, now we know that, okay, this particular baby had a discordance of around 35%. So now this is moved on from discordance and this is now FGR. So how would you define selective FGR in dichorionic and monochorionic twins? Because now we have to have that FGR in mind and now we take it on from there. So Dr. Soumya?
Thank you, ma'am. And good evening to all. So as per the recent Delphi consensus in 2019, we define FGR or selective FGR as an estimated fetal weight percentile of less than 3rd percentile. And for dichorionic and monochorionic twins, we have different criteria. For dichorionic twins, we say it as a selective FGR if 2 out of the 3 features are present. That is an estimated fetal weight of less than 10th percentile, discordance of greater than 25th percentile, and an umbilical artery pulsatility index of more than 95th percentile. Whereas in monochorionic twins, there is an additional point, which is abdominal circumference of less than 10th percentile, and presence of any 2 out of these 4 features, then the fetus is labeled as having selective FGR.
Right. And Dr. Soumya, could you also talk about the other types of SFGR which do exist?
Yes, in dichorionic twins, for labeling the types, it is same as that for the singleton pregnancy. There are 4 types based upon the umbilical artery, Doppler, and ductus venosus flows. So type 1 SFGR in dichorionic twins will have umbilical artery pulsatility index of greater than 95th percentile or a cerebroplacental ratio of less than 5th percentile. Type 2 will have an absent end diastolic flow in the umbilical artery. Type 3 will have a reversed end diastolic flow or ductus venosus pulsatility index greater than 95th percentile. And type 4 will have reversal of A wave in ductus venosus. So it is same as that for singleton. Whereas in monochorionic twins, it is based up, there are 3 types based upon mainly the umbilical artery flow pattern. So type 1 SFGR in monochorionic, the umbilical artery flow will have positive end-diastolic flow throughout cycle, but greater than 95th percentile. While stage 2 will have an absent or reversed end-diastolic flow in all cycles in the smaller twin. And stage 3 will have an intermittent absent or reversed end-diastolic flow. So, and also there are stage 4 and stage 5 in which there may be superimposed TTTS or intrauterine demise of the smaller twin.
Right. So this particular classification of monochorionic is important because that is that actually guides the management. And I've added this classification, which is more recent and practical in terms of intervention, which would be required. Because once you have a monochorionic twin with absent end-diastolic flow, you would want to probably think of termination of pregnancy. So what happened to this particular? We'll come to the monochorionic part later, but just to discuss the dichorionic part here. What happened to this baby? So this baby moved on to 22 weeks. The discordance kept on increasing. At 24, it became 56. And then at 26, it was, the discordancy continued. And at 27 weeks, we found that there was an absent and reversed end-diastolic flow. However, there was some forward flow in the DV. Now, the question, Dr. Kritika, would be that, she's a 27-weeker, one of the babies has around 643 gram, the other one is around 1100 grammer. So what would you do for the baby now? What is the plan? Would you continue this, deliver both, or conservative and allow IUFD of one twin? I think this is something that you have to tell us.
Thank you very much, ma'am. So, as we are dealing with the case of dichorionic diamniotic pregnancies, a very important point is that in this case, we have some advantage that there is no shared vasculature between both the twins. And the only risk which we are dealing actually here is the risk of iatrogenic prematurity of the AGA fetus. And there is no practical DIC risk in mother if we lose one of the smaller twins. And second thing is, since there is no shared vasculature, even if the SGA twin has a premature demise, so there is no neurological damage to the co-twin because there is no shared vasculature. So what we will do is we have to strike a balance between the timing of the delivery, so as we prevent a very mental handicap in the SGA fetus, and we also prevent the iatrogenic premature delivery of the AGA fetus. So what we'll do is, for this case, I would like to wait up till 30 weeks. For as expected management, I would not do anything up till 30 weeks. And if I would just continue the weekly Doppler scans for this patient. And if by chance my SGA fetus is surviving till that weeks and the DV flow is normal, so after 30 weeks, I would like to base my delivery on the condition of the IUGR fetus. So this will help me in making a striking balance. And then after that, I'll manage the pregnancy by monitoring AFI, CTG, and BPP as we do manage for a singleton pregnancy. So this, if I do the alternate, then I will end up with a more morbidity for both the fetuses. So, and the survival of the AG fetus will also be doubtful.
Right. So I think, thank you, Dr. Kritika, for putting it across. I think it's a very important point that we need to understand that unnecessarily, rather than delivering both. So this I have taken directly from the ISWOG guidelines, that counseling should be on a case-to-case basis, taking into account the risk versus benefit. But it is generally not recommended in dichorionic twins to deliver before 30 weeks of gestation. So it's all right to let one of the babies go, so that at least one baby reaches 30 weeks of gestation, so that there is a quality life given to that baby. So this baby was followed up, delivered at 32 weeks for severe preeclampsia, and both babies survived with a baby weight of 2.1 and 1.1 kg. So essentially, we kept on following those babies. Thankfully, those babies survived, but the patients were counseled that any time there could be a demise of one of the babies. So it's important that in a dichorionic twin, even if it is one baby is pre-terminal, we do not provide iatrogenic preterm delivery to the other baby because of one twin. So that's an important point that we wanted to put across. So Dr. Akhila, before we wind up this particular scenario, I just want to put across a basic principle of how you follow up an antenatal plan twins, because we don't follow up the twins in a routine antenatal clinic just by a per abdominal examination. What is your plan for follow-up?
So we all know that monochorionic twins are special and we need to monitor them more closely for complications. So after a good 11 to 14 weeks scan, if all is well, call them at 16 weeks, and starting from 16 weeks, every 2 weeks, follow them up closely up till 26 weeks at least, because that is the time most of these problems will start showing up. When it comes to dichorionic twins, if your NT scan is good and your screening is good, I think it is okay to call them around 19 to 20 weeks, do a good anatomical survey, look at the cervical length, etc. And then once in 4 weeks, if all is well. So that is the standard guideline for follow-up of dichorionic twins. As long as things are going on okay. Of course, if you find a problem, then depending on the intensity of the problem, you have to increase the surveillance.
Right. So thank you, Dr. Akhila. I think 4 weekly for dichorionic and 2 weekly for monochorionic. I think that is our mantra for managing twin pregnancies. So thank you very much. So we come to the third scenario, where we said that, in a dichorionic twin pregnancy, this babies did well, both of them survived. But there was this another lady who came with an intrauterine death in one of the twins. And this was a dichorionic twin. So quickly, we have around 20 minutes left. So I would just request that, just what would you do? So this was a dichorionic twin, 27 weeks. She was already a chronic hypertension with superimposed preeclampsia, and she had IUD of 1 twin. So Dr. Asit, what would you do in such a patient? And we have a lot of apprehension here that, okay, this is a mother who has preeclampsia and one baby has already died. So would you rush and deliver this patient, or what would you do in such cases?
Ma'am, in such cases, the management plan is guided by risk-benefit analysis, assessment, and parents' wish, as well as neonatal and obstetric considerations. In this particular case, we have an added risk of chronic hypertension with superimposed preeclampsia. So our primary aim is to manage preeclampsia. If it is controlled with medications, we go ahead, monitor her weekly with Dopplers and growth as we do. Then plan is to at least continue till 34 weeks and if possible to 36, 37 weeks. But at the same time, at any time, if her preeclampsia is uncontrolled, we need to deliver her. Give her magnesium sulfate, give her antenatal corticosteroids, and deliver.
Right. So I think quickly, very nicely summarized, Dr. Asit, very clear that co-twin death is not an indication for delivery unless there is another maternal indication. So that's a very nice summary. And this is what we can share as data, that the risk of co-twin death in a dichorionic is 3%, preterm is 54%, and neurological impairment is 2%, while that's the same for a monochorionic is 15%, 68%, and 26%. So this is from a large data set which is presented. So essentially, in a dichorionic death, whatever has happened at the time of death. So even if we rush to deliver the other baby, we are not going to, do any benefit to that baby. So they are likely to suffer. So whatever gestational age at IUD is related inversely to the gestational age at delivery. Earlier the IUD, earlier will be the gestational age. So immediate delivery is not advisable, reasonable to monitor and refer to a fetal medicine center. Scan 2 weekly if it is a monochorionic and 4 weekly if it's a dichorionic. And fetal brain imaging after 4 to 6 weeks post IUD. So there is no rush to go and delivery if there has been a single fetal demise inside the in utero. So this patient was managed conservatively. However, after 6 days following IUD, this baby had a decreased fetal movement. So a cesarean section was done for a 960 grammer baby who was SFD with an APGAR of 6 and 9. Now, the next case scenario is a primigravida, a DAMC twin who had mild ventriculomegaly in T1 and FGR and AEDF. Now, interestingly, this is not I have created, this is how the patient came to me 2 days back. She's on the cusp of 26 weeks. So I'm just putting it out there for a quick discussion, and then we move on to the next scenario. What would you do with this patient? Now she's 26 weeks, monochorionic twin, pre-terminal patient, and currently the patient is lost to follow-up. She's refusing to follow up. We have called the patient 3-4 times, but she's not coming to us. But what would you do with this patient? Dr. Meenu.
Yeah. So thank you very much for this.
Googly.
Now, so let me ask you 2 questions here. it's the same fetus who has the Doppler change as well as the ventriculomegaly.
Yes. So essentially, this patient came to us earlier and we have done an amniocentesis for that mild ventriculomegaly and the report is normal. We confirmed in the morning. The genetics people told us that their report is normal. So she was initially following up with us. We said, okay, fine, this is fine. Like only mild ventriculomegaly, rest everything is normal. So she was fine, when she came to us at 17 weeks, the growth discordancy was not very much. Now, once she's come at 26 weeks, now she has absent flows. She was a monochorionic twin. So now, tell me.
How's the progression of the ventriculomegaly?
Same. It's not increased.
Yeah. So I don't think so. I'm worried that much about the ventriculomegaly.
Yes, I'm not. Yes.
What I'm worried about is the selective IUGR that I'm seeing here. And as per the modified classification, I would call it as type 2A. Now, since she is at that gestational age of 26 weeks, even if the patient has not come back to you, we are nowhere the deciding factors. So we need to lay our cards on the table, explain to the patient what are her options. So the options here would be an expectant management versus if she really wants to act upon the fact that there is selective IUGR type 2, because we know that in type 2, there is a small chance that this baby can end up into a sudden intrauterine death. But also we know that if the patient wants, we can put her on a twice weekly surveillance and try to continue this pregnancy till around 30 weeks of gestation and decide for delivery. However, if the patient is very adamant that no, I want to go for a selective termination, then depending on the expertise of the person who is in your center, you would discuss the options of RFA versus bipolar cord coagulation. Of course, you have to look at the technical consideration of how accessible it is, and ultimately it is the patient who would decide. So if you go for expected management, I would say biweekly surveillance and deliver her at 30 weeks. If it continues like this, unless and until your DV, the DV here will be a prognostic tool, I would say. But if she wants a selective termination, then as per the patient's choice and your expertise, we need to decide which method we go, making the patient understand the risk of preterm delivery that is associated with the procedure.
Yeah, I think Dr. Meenu, nobody could have answered it better. I think you've given like all of it out there and left everything to the patient to decide. But I think that's perfect. So after viability, impending IUD, so yes, delivery is an option, but she's just in that window of 26 to 27 weeks where we can intervene. After 27 weeks, we would also not like to, do anything much. So yes, given the option to the patient, if she is waiting for intervention, otherwise, as we said, we will monitor by DV, do a strict fetal monitoring and try and continue the pregnancy as much as possible, then give steroids and deliver the patient. So I think that is what we plan to do if the patient turns up, because we've called her 3 times and then she's like, whatever is happening, why the doctors are calling so much. So anyway, we think we are more worried than the patient. So let's see what happens to this. But yes, that's the plan in a monochorionic, Yes, anybody wants to say something?
Yes, ma'am. Ma'am, I want to just ask you one thing, that I also had a similar patient, and in monochorionic gestation, what I have seen is that because of arterial anastomosis, this end diastolic flow sometimes take almost 2 weeks to convert to reverse diastolic flow. So it is not the same pattern as we see in a singleton pregnancy or in dichorionic pregnancies. So how reliable is that? Because I had such pregnancy and it followed up till 30 weeks and there was no DV reversal in the SGFR. So
I completely agree with what you're saying, and that's why I showed this classification of 2A and 2B. And that's why these things are coming up, that when you talk about this 2A and 2B and stage 3 where there is abnormal DV Doppler, when the DV Doppler becomes abnormal, this is the recommended intervention phase. Right. So this is why we talk about this classification, and I specifically put this classification here, that even in the SFGR of monochorionic twin, even the AEDF can go on for a very long time. And that AEDF alone is not an indication for intervention. Because we understand the anastomosis in a monochorionic twin are protective. So that is why the intervention is when you have an abnormal DV Doppler in the smaller twin. So that is what Dr. Meenu also said, that surveillance, DV Doppler, and yes, so because the problem with it that after a week we cannot intervene even if we want to, and we end up delivering that patient. So we have a very small window for intervention. So that is why we might want to err on the side of intervention if the patient is willing. That is the reason we want to talk about this right now. So the next point was actually to talk about the intervention, but I think the intervention specialists have talked about it a lot. So we can skip this part and we go to the next scenario. So this was just about the razor and RFA, which people have talked about. So we talk about the next scenario. We have another 10 minutes, the last 10 minutes. And I think this is something that is completely gray. There is no black, there is no white. I think everybody gives progesterone and we are just trying to justify why we give progesterone. So everybody does a cervical length and everybody is wanting to justify why we do a cervical length. So this lady came at primi gravida, 18 weeks and 3 days, IVF conception, DADC twin, and short cervical length on ultrasound, completely asymptomatic. So Dr. Soumya, what is the role of routine cervical length screening in twins in the second trimester? Is it helpful? Should we be doing it?
Actually, there have been many studies, but as per IFIOG guidelines, also a cervical length assessment should be done around 18 to 24 weeks of gestational age, even for twins. Although it may not be as good a predictor for preterm labor as in singleton gestation, but it has been found if the cervical length is less than 25 it does predict an increased risk of preterm birth before 28 and 32 weeks. And if it is less than 15 then it is a greater predictor of preterm birth. And some intervention or some steps may be taken at this gestational age to prolong the pregnancy. So it should be offered to all at 18 to 24 weeks.
Yes. So you are doing cervical length for all twins at the anomaly scan. So I think this is quite logical. So the question comes in because, the twins are anyways at a higher risk and whether doing a cervical length would or would not help. But it has been seen that if you do in a meta-analysis, that if you do a cervical length and it is less than 25, then it increases the risk of preterm vaginal birth at less than 32. So there is enough evidence to say that a shorter cervical length predicts preterm birth. And this is the 2024 NICE guidelines, which says that you offer a single cervical length scan between 16 and 20 weeks to women who are twin pregnancy or triplet pregnancy. So there is enough justification with evidence, and there is also guidelines to say that we should do a cervical length. So that is there. Now the next is what is a little this thing. So what is the role of progesterone supplementation? When and which progesterone? Dr. Kritika.
Yes, ma'am. So there is definitely a role of progesterone supplementation, and all the evidence points that progesterone definitely decreases the risk of prematurity by at least 25 to 30%. And since we don't have any evidence against any of the other factors like bed rest, prophylactic tocolytics, or lifestyle modification, so we don't have much to offer to the patient. So, and we just cannot stand not writing the progesterone when we know that this is the thing which is going to help us. So I would definitely start progesterone from 20 weeks and will continue it up till 34 to 36 weeks. And we have both the options: micronized natural progesterone in a vaginal route, and then injectable progesterone, 17 alpha hydroxy progesterone caproate. And both of them, most of the studies have a comparable benefit for both of them, but some studies have mentioned that there is a slightly less desirable side effect profile for the 17 alpha hydroxyprogesterone caproate. But still, I prefer 17 alpha hydroxyprogesterone caproate, but because I don't know, it gives a placebo effect to the patient that we have to come weekly for the injection and we are under some surveillance, or I don't know, but it has shown a better result.
Right. I can see the passion over there. No, but Dr. Kritika, thank you. The evidence actually says, as you said, that there is role of vaginal progesterone, and it has been seen that treatment with vaginal progesterone was associated with significant reduction in the rate of preterm birth. So there is no two ways about it. And the NICE 2024 says that if you offer a 200 milligram vaginal capsule once a day at bedtime to women and pregnant people with a cervical length of 25 or less. So I think patient selection is extremely important, and continue the treatment until 34 weeks. So once you have done a cervical length, let's say 16 to 20 weeks, and the cervical length is less than 25, then we should continue the treatment till 34 weeks. So I think that is extremely important. So that message, I would just like to put in one advisory here that IM progesterone should not be given any longer. There has been an advisory against it. So if we are practicing it, so we should try and avoid it. It is there in the guidelines now, and also there has been advice so that it doesn't. One is the efficacy, but the side. So essentially, we have stopped practicing giving IM progesterone. So let us try and avoid giving it. Whenever we are giving, give vaginal progesterone. I think that is something that works. Right now. What about the first trimester? So we know that we have to give this in the second trimester. Does it work in the, so because we are ultrasonologists and, as radiologists and fetal medicine people, we will always screen in the first trimester also. We can't help it. So does it work, screening in the first trimester? Dr. Meenu.
All these kind of controversial questions. Okay.
I didn't plan it. It just happened.
See, when it comes to screening in first trimester, I don't think so there is any data that really says that, it is really effective to screen with the help of cervical length. But yes, we personally end up doing it for the fact that to see some kind of anatomy, sometimes for the fetus that is lower down, we end up doing transvaginal for almost all of our patients. So yes, we do end up doing a first trimester cervical length screening, but I would not say that it is very effective. And talking about progesterone, I would not be the right person, but I did read a little about the event trial where they said that, it should not be given universally to everybody. So as you said, patient selection is very important. So it would work probably only in patients where you have a short cervical length. At the same time, the study also showed that if you start giving it to people who are having a normal cervical length, say of around more than 3 centimeters, you're actually causing more harm rather than causing them benefit because of the progesterone. So yes, you use it, but be wise when you select your patients.
Absolutely. And I think that's extremely important and very well put. And this was the trial which talked about it, that when they gave it to all, it didn't work. But in the post hoc analysis, when they looked at the people who had a cervical length of less than 3 centimeter, it helps. But in fact, if you give it to people who are more than 3 centimeter, it doesn't really work and it actually harms. So we should not be giving vaginal progesterone to everybody at the first trimester. But yes, people who are doing a nice first trimester scan will look at the first trimester cervical length and probably act on it. So Dr. Akhila, what is the role of cervical cerclage? I'm sure we all come across people who put cerclages for twin IVF, twin fetal reduction, twin fetal uterine malformation, or just twins. Put cerclage.
So
what do you think?
A procedure which is next common to episiotomy. It's looking like that. It's done very often without evidence. So when the cervix is less than 1.5 centimeters, there is some evidence to say that cervical cerclage improves the latency to delivery and it does significantly reduce the risk of preterm birth. But between 1.5 to 2.5, there is really no strong evidence to recommend a cerclage.
Right. So I think that's very succinctly put. And this particular meta-analysis actually says that if the cervical length is less than 15 mm or the cervix is dilated at more than 10 mm. So essentially, it is a way of emergency procedure. So emergency cerclage, ENCIRCLAGE was a trial which was actually done. And they said that if it is an emergency procedure, if you find a very short cervix, then you put it, but not as a routine indication in a twin pregnancy for a short cervix of say less than 2.5. So do not put it as an elective. It is more harmful than it is useful. So this is what is the role of cerclage, physical examination indicated, or an ultrasound when it is less than 1.5 mm. So I think that is the role of cerclage. So Dr. Asit, the final word, in unselected twins, routine twins, just because they are twins, would you give progesterone?
Ma'am, as we know that multiple pregnancy is the single most important predictor of preterm birth. So many studies were there to study how if we prophylactic use of vaginal progesterone to prevent preterm birth, but none of them they suggest the routine use of vaginal progesterone to prevent preterm birth in all pregnancy, all twins. But as you said, if the cervical length is less than 3 mm, less than 3 centimeter, then there is an added advantage. But ma'am, I don't know, it's a gray area. It's always under discussion, and we would like to discuss with the primary obstetrician, with the patient, and we take the decision accordingly.
Right. So completely agree without any previous factor. But if this patient had a prior, preterm birth, and this time it's a twin pregnancy, you can consider Other factors you can consider, but primarily unselected twins, definitely we would not consider progesterone. So this pregnancy, because she came with a very short cervical length, cerclage was placed. However, she did have a preterm vaginal delivery at 23 weeks and 6 days, and both babies were 540 and 560 grams. So to summarize the prevention of preterm, cervical length should be done between 16 to 20 weeks. Vaginal progesterone should be given if the cervical length is less than 25 mm, and cervical cerclage should be placed if the length is less than 15 mm. So that is more like an emergency cerclage which should be placed. So these are the only 3 key points which is important for the prevention of preterm in twin pregnancy. So now, Dr. Sita, we've just kind of, finished our time. I think we'll just take 5 minutes to finish the last part, which is the delivery part. And Dr. Anu has refused to answer this part. So I've removed her name from there. So timing and mode of delivery, just a last bit of conclusion from our panelists. So Prime at 36 weeks, DADC, both breech. So I've just given 3 case scenarios. So this Dr. Kirti, Soumya and Kritika, you can take. Dr. Kirti, when will you deliver this patient? Prime 36 weeks, DADC twin, both breech. And when will you deliver and how will you deliver? Kirti.
If they are uncomplicated, then they can go up to 38 weeks. 38 weeks to 38 plus 6, that is the current recommendation. Since the first is a breech, then a cesarean section would be advised.
Okay, great. And the second is Soumya, second gravida, previous one abortion, 35 plus 1, DAMC reduced to singleton, both breech. So DAMC must be an RFA.
When it is reduced to singleton, it has to be managed as a singleton pregnancy only. And based upon the present growth of this fetus and the Doppler study of this fetus, the timing of delivery should be planned accordingly. If it is uncomplicated, then again 38 plus should be the target. And cesarean section will be required because both fetuses are breech.
Okay, so this is again, so this you would go around up to 38 weeks. Okay. So post RFA, yes, of course you will want to see the growth. And this Kritika, 3 weeks, triplet reduced to DAMC twin, first cephalic.
So 30 weeks pregnancy and monochorionic twins. So this will behave as a monochorionic diamniotic pregnancy because we have reduced the triplet, and we should monitor with weekly Dopplers, and if everything is fine, we can take this pregnancy. I think they should be electively delivered at 36 weeks. And if the first twin is cephalic, we can give a short trial of labor, and it has to be decided upon the diamniotic monochorionic twin is not a direct indication of cesarean section, and obstetric indications have to be taken into account. So if first twin is cephalic, we can give a short trial of labor.
Yeah, absolutely. So I think this is absolutely correct. So just to summarize, what really happens is that in a dichorionic twin, it is always the the risk balance ratio of what is if the risk of neonatal death versus the risk of IUD. So by 37 weeks, the risk of IUD becomes more than the risk of neonatal death. So the delivery of the dichorionic twin should be done after 37 weeks. So 37 to 38, and that is why it is recommended that anytime after 37 weeks, the dichorionics should be delivered. While in a monochorionic twin, after say up to 35 weeks, the risk is quite high for the neonatal death. But by 37 weeks, the risk becomes higher for the intrauterine death. So any time between 36 to 37 weeks, the monochorionics should be delivered. So the various guidelines tell us that for NICE, the dichorionics should be delivered between 37 to 38 weeks, and the monochorionics should be delivered between 34 to 36 weeks. In our personal practice, intervention monochorionic twin, if they are doing well, we do deliver between 36 weeks. Even if they're doing well, 36 to 37 is the max that we go. And of course, if they're complicated, then 34 to 36, whenever they are, we are able to deliver. And like you said, if the first twin is vertex, then vaginal delivery. The first twin is non-vertex, then cesarean. And if it is a vertex and non-vertex, then if we are, feeling very, very enthusiastic, then we do give a trial of vaginal delivery. But definitely, mostly they do end up having a cesarean section. So this patient, yes, the DAMC reduced to singleton. Like I said, after an RFA, we generally do not try and go beyond 36 weeks. And the triplet reduced to DAMC twin, depending on the complications and how they are doing, 34 to 36 weeks is what we do. So just to conclude, I would just like to say that the chorionicity should be determined at 13 early pregnancy scan. and should have the first trimester scan, dichorionic pregnancy every 4 weeks, and a monochorionic pregnancy should have scans every 2 weeks. The screening should be performed by the first trimester screening using NT, age, and the biochemistry. Cervical length should be the preferred method for screening for preterm, and 25 mm is the cutoff. Intertwin discordance of more than 25% should be referred to a fetal medicine center. Single IUD in a twin pregnancy, it should be referred, and it is not an indication for an immediate delivery. And strict monitoring protocols and timely referrals can ensure a good outcome. And important to remember identify the red flags, and timely referral can ensure a very good outcome. So I would like to thank all my panelists for a very enthusiastic participation. I really had fun preparing this panel, and I'm sure all of you, thank you for your participation, and we did have a great participation. Thank you very much.
Thank you, ma'am. Thank you so much.
Thank you. Thank you, Aparna.
Thank you, Dr. Aparna. Brilliant that was. I think we've had a complete, webinar on multiple pregnancy covering all aspects. Whatever was not covered, you've brilliantly covered those. Thank you, Aparna, and thank you to all the esteemed panelists, Dr. Akila, Ashit, Dr. Ashit, Dr. Saumya, Dr. Kritika, Dr. Meenu, and Dr. Kirti. Great, Dr. Asit as well. I think Prasanna has asked one question. Which charts would you recommend? If we plan to use customized growth charts, which charts should we use?
So currently there are, I think who was telling, Kirti, that there are centiles from the FMF available now, which you can use. And also there are charts available from Dr. Asma Khalil and group, which you can use them. Currently they are not available in your ultrasound machines, but you can download them from the web and you can use them.
So as you said, we are not using them. Are you using them routinely?
No. Like I said, no, not now. But I think we can start using them.
We'll have to start with. Yeah. Thank you.
And I would like to wish Sir for best of luck for his.
Thank you. I think he's already.
His left.
No, I'm still not yet. Not yet. Thank you very much. I just jumped into the 17 OHP debate. Apart from the fact that the initial data wasn't strong enough, all of us were using it. But the reason that US FDA has withdrawn the approval is because there's an increased risk of childhood cancers in babies or mothers who got 17 OHP. That is the reason we should not be using it. It's only vaginal.
Yes, sir.
People who tend to be less compliant or less, accepting the vaginal, if we put this, strong evidence, they would be more convinced to take the vaginal.
Yes. Now, when patients complain of the compliance things, I tell them that this is the only option you have. Anyway, I think because my flight was delayed, I got to hear the entire thing, and I think it's fantastic webinar.
Thank you, sir.
Thank you. Any questions, Prasanna, which I have not seen?
No, ma'am. Nothing else. It was fantastic.
Great. Yeah. Thank you. So I think the only messages that we can take for messages, please avoid iatrogenic prematurity of these twins who are already compromised, and make sure they reach their final.
And also surplus in twins.
A huge debate to follow. Thank you. Thank you all once again. Have a great day.
Thank you, Aparna. Thank you to all the respected panelists.
Thank you very much.
Thank
Bye.
you. Bye.
Thank you.
Good night.
Thank you.